Thank you very much. Thank you very much. And I'm aware I'm going to go into your lunchtime, but I hope I will still be engaging for at least 10 minutes. Many congratulations to the HRB on the 30th anniversary. And it goes without saying that the research capacity building and excellence in Ireland wouldn't have been there without the HRB. With regard to the NSRF, the National Suicide Research Foundation, is in existence since 1994. I joined the NSRF in 2013. And in that time space, going from 1994 until today, there have been only a very few years where we hadn't the support of the HRB funding. So we're very grateful for the support and capacity building in the mental health research, but also in self-harm and suicide prevention. What I would like to cover in about 10 minutes here is just give you a quick update on suicide and self-harm in Ireland, focus on evidence-based mental health promotion, and particularly how can we build resilience and identify hidden cases of self-harm in an evidence-based way. I would like to give you some examples on evidence-based interventions for self-harm in health services, including mental health services. We've come a long way, particularly since I started working in Cork in 2003, but we still have to close a number of gaps. And in closing the gaps, obviously, hoping to prevent more cases of self-harm and suicide. At the highest level, then, when people deal with the aftermath of suicide, a lot of work has been done, but we still have to enhance the capacity building in improving support and preventing further suicides. As I said, in so many years, we benefited from the HRB funding, so I will, in the examples that I will show you, there's examples where HRB funded interventions in a primary capacity, or sometimes we were there as a co-applicant. This is an overview of trends in suicide in Ireland since 2004, and it's very clear that obviously the highest rates are amongst men, and it also goes without saying that we see peak, in fact, 2 subsequent peaks during the time of recession, and in a relatively short space of time, there was a 15% increase in male suicides in Ireland, and something that we haven't seen historically in that short space of time. Based on some of the in-depth investigations, we know it's not simply unemployment or economic adversity, it's the combination of socio-economic, mental health factors, but also, unfortunately, austerity factors. In Ireland, we have a unique system in operation, the National Self-Harm Registry. On that basis, we were also able to see what happened with self-harm during this time. And again, very consistent with suicide, we saw a very significant increase in male self-harm in Ireland, and again, in a very short space of time. The increase in male self-harm was 30%. Never I've seen such an increase in such a short space of time. And you can see that in that period of time, the gender ratio was narrowing. A little bit of good news that we're coming down in recent years, but overall we're still significantly higher in terms of self-harm compared to the time before the recession. As in the introduction was indicated, as soon as I started working in Ireland, I started working with colleagues on the first national suicide prevention strategy. Last year, we were very fortunate to launch the second new national strategy to reduce suicide. And the biggest differences between this strategy and the previous strategy, first of all, this is overall a strongly evidence-based suicide prevention strategy with clearly identified evidence-informed actions and goals. The other key point is that before the launch took place, there were signed-off actions between Department of Health and other government departments. So the cross-departmental approach was very unique. And globally, this strategy has drawn a lot of attention. So at the launch, Dr. Shekhar Saxena, the Global Director for Mental Health, was present, and WHO is promoting this strategy as a template for suicide prevention globally. After some positive news, some less positive news. This is the big challenge in Ireland that we're facing, the big iceberg that myself and my colleagues carry with us for years. So first of all, at the population-based level, co-funded research from the HRB has shown that on average, yearly we see 60,000 cases of hidden cases of self-harm. Self-harm doesn't come to primary care or any other healthcare services. Then, with the benefit of the National Self-Harm Registry, we see on average 11,000 cases of emergency department presentations of self-harm. Currently, it's 11,000. During the recession, it was close to 12,000. And via the CSO, then we have annually around 550 cases of suicide. On a positive side, if you look at the different boxes, I'm now able to give you some example of specific evidence-based and effective interventions that gear and are tiered to all three levels. So people in the room here in policy, if they would say, which level would you prioritize or which level would you choose? I would say on the basis of the evidence, we can't prioritize any level. We should target all levels at the same time. So at the bottom level of the iceberg, a number of evidence-based or evidence-informed interventions that's currently ongoing or that have started is the HSE-funded Little Things campaign. It's a national public awareness campaign, and here you see an example of where we try to highlight the adverse effects of alcohol use, abuse, and binge drinking. And still overall in Ireland, as in many other countries, alcohol is being promoted as having all kinds of positive outcomes and effects, but we deal with the aftermath and the negative effects. The beauty of having national surveillance data is that since a while ago, we identified that the peak times in the year for alcohol-related self-harm are consistently either on public holidays or the first day after and the second day after national public holidays. So in terms of capacity allocation, we know what to do when we know or we can anticipate alcohol-related peaks of self-harm. At the school-based level, fortunately, we have growing evidence of evidence-based interventions, and an originally EU-funded project, Saving and Empowering Young Lives in Europe, was also awarded for HRB ICE project, and it's currently one of the approaches with the most effective outcomes on improving young people's emotional resilience and self-esteem, but also reducing self-harm repetition, and reducing suicidal ideation. So with the support of the HRB funding, we try to promote this as a national program. And then there have been many different funded projects in terms of looking at the effectiveness of so-called awareness and skills training amongst a range of healthcare professionals, but also community-based professionals, and with very consistent outcomes on increasing confidence, changing attitudes, and improving knowledge. So here you see the picture of the National Self-Harm Registry, which initially was also recommended and rolled out in Northern Ireland as a template, and WHO currently, since last year, is now promoting this as a global template, and this came together with the NSRF being designated a WHO collaborating center. A little bit of good news, in addition to still the many challenges that we have. So you see below that amongst the people who are presenting to the emergency department, 73% of the people receive an assessment in the emergency department and subsequent recommended aftercare. Years ago, this was much lower, so we're going in the right direction. But talking today about NICE, we should be talking here, or ideally about 100%, because amongst the people who leave the front or the back door of the emergency department, there's also people who have engaged in highly lethal methods where the risk of subsequent suicide is very high. We still see that 13% of the people coming to the emergency department leave without being seen, without any aftercare. And again, there are amongst these people who are subsequently at very high risk of suicide. However, again, with the evidence-based information, since last year we have national guidelines for assessment and management of self-harm. The NSRF and colleagues from psychiatry and nursing were heavily involved in establishing this document. It has many links with the NICE guidelines, and now we're on to trying to implement this at the national level. The registry data has helped us to allocate or to identify emergency departments with high volumes of self-harm patients, and on this basis we were able to convince the HSE to allocate so-called self-harm nurses depending on the capacity required in the different hospital departments in Ireland. And globally, one of the psychotherapeutic interventions that has shown consistently to be effective for self-harm patients with multiple repeated episodes of self-harm, the so-called dialectical behavior therapy, is currently being rolled out also at national level, but very much in a stepped approach on the basis of where, in which hospitals do we see the majority of people who repeatedly engage in self-harm. Together with the HRB and the National Office for Suicide Prevention, we're moving towards setting up a national task force to address frequently used intentional drugs. And again, our surveillance system, the registry, has shown benzodiazepines, unfortunately, is year on year one of the drugs that's most frequently used in overdoses. Alcohol, no news again, but we have to keep pushing the pillar, but this time with evidence behind us. I'm obviously very fortunate last year to be awarded the 5-year HRB Leadership Award, and one of the key targets there, and we have started this work, is to focus this time particularly on self-harm patients who usually are quite challenging to engage with in terms of assessments or aftercare interventions. And these are people with multiple repeated acts or people with highly lethal self-harm. So I'm able now to work with a small team and build capacity to address and approach these people, first of all for interventions, for an interview, and subsequently with more appropriate referral to evidence-based interventions. And a very ongoing challenge still in Ireland is self-harm and suicide amongst homeless people. And again, our evidence has indicated that during the time of the recession, there was a twofold increase in self-harm rates amongst people who are homeless. In terms of the upper level, the last level of the iceberg, one of the big challenges in surveillance and being able to talk about the appropriate figures or appropriate risk groups was the huge delay, obviously, that we always have with getting the data on suicide mortality from the Central Statistics Office. So in 2008, we took up the initiative to set up a new system, Suicide Support and Information, where we directly link in with coroners, with bereaved family members who are open to work with us, and also with healthcare professionals who were the last persons to have engaged with the deceased. So on that basis now, we have in the South a systematic approach to examining consecutive cases of suicide and also even open verdicts. So here you see some outcomes of the relevant characteristics of people who died by suicide. No news that it's more over men. A large proportion were unemployed at the time of that, but at the same time, you see here reflected the comorbidity between socio-economic characteristics and mental health adversity, particularly depression, previous self-harm, alcohol, and drug abuse. I think a slightly neglected group is then the people affected by suicide, and unfortunately during the recession, during certain specific times, you see mental health and health issues being magnified, but we came across families where 3 or 4 family members had taken their lives. And there it's crystal clear that there have been gaps in terms of aftermath or particularly the aftercare and the support for these family members. Again, with HRB support, we were able to do a follow-up amongst family members who were interviewed following bereavement by suicide. And nearly 5 years on, 1/3 of the family members still report post-traumatic stress symptoms. 25% still report suicidal thoughts. So this is really key evidence for a proactive approach for high-quality support after a suicide has occurred. And this presentation is probably a bit timely in light of what I call confusion in the media last week, where there were different figures reported about a potential cluster of suicide in Cork. And we were almost anticipating with our work that there is a greater need for what we call so-called pulse systems, so where we're able to identify emerging clusters of suicide and self-harm as early as possible. And the importance of that is to anticipate in Ireland or in specific areas where is there an intensive response or a greater need for certain interventions when an emerging self-harm or suicide cluster occurs. It's a very multidisciplinary approach. We're working here with the National Centre for Geocomputation in Maynooth to do specific geospatial analysis with the registry data and the data from the Suicide Support and Information System, and we work with colleagues in Melbourne and Griffith University, Australia. This is in fact a key pillar that's primarily funded by the HRB. So if last week we would have had this pulse system already in place, then I'm sure there would have been less confusion about the figures. Again, with an individual HRB scholarship funding, a few years ago we were back to already do some advanced geospatial analysis on our self-harm data. And in 2 areas in Cork, this was 2012, at the start of the year, we identified 2 significant self-harm clusters amongst men, predominantly men. And interestingly, in the second half of that year, in a neighboring area, we identified a significant cluster, but only amongst men. So that brought to us the thinking or the hypothesis, would it be possible if you see a highly lethal self-harm clustering or increasing in a certain area, could that be an indicator of subsequent suicide, particularly amongst men and men using highly lethal methods? So that is one of the key elements that we're going to approach in this HRB-funded pulse system. So just at the end, then, a number of key actions and recommendations which echo recommendations and evidence from earlier today. So in our area, it goes without saying that multidisciplinary collaboration and partnerships are key. Currently, I'm also involved with Joe Barry in working towards a new alcohol-related partnership application. That's obviously very key in our area as well. Taking into account the iceberg, we know exactly then that intervening at one of the levels will probably not bring about significant changes overall, certainly not at a national level. So the multi-level approach, first of all, to address all the target groups and target areas, but also to try to achieve synergistic and sustainable effects is key. And whilst we now have an evidence-based national strategy, there should be both a bottom-up and a top-down approach to make sure that the evidence is understood in all the different areas in Ireland where hopefully we can continue and progress with implementing the key actions in suicide prevention. And if for you who looked at my title, you were wondering why was I putting emphasis on changing life? First of all, on the basis of the evidence of the last years, we know that it's possible with the right interventions and the right implementation to change people's lives. But here I'm putting a quote of 2 very well-known Dutch writers. My roots are still in the Netherlands, but I feel very Irish. But these are 2 Dutch writers who biographically wrote about their depression and repeated episodes of self-harm. And interestingly, they both consistently stated on none of the episodes of self-harm they wanted to die. What they wanted was a different life. And we now are more equipped, and we know in many ways how we can support and help people to change their lives. Unfortunately, both writers took their lives despite being open, despite being able to communicate about their challenges in life. And here the acknowledgement, certainly the HRB, obviously, but also the HSE National Office for Suicide Prevention, who provides core funding to the NSRF, and obviously my colleagues who are working with us in the NSRF on a long basis. So, Gorif Mat Agat. I tried to do my best. So thank you.